Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Pediatric Seizures, Episode 3, Prehospital Management. After watching this episode, participants should be able to understand goals for treatment of seizures in infants, children, and teenagers, review pharmacologic treatment of seizures in infants, children, and teenagers, and review non-pharmacologic treatment of seizures in infants, children, and teenagers.
The official definition of status epilepticus is a seizure that's lasted for longer than 30 minutes. Once a seizure has lasted that long, it becomes very difficult to control and falls into a category we call refractory status, which means that it's resistant not just to the benzodiazepines, but often to other kinds of medications that we use once the patient has arrived in the hospital too. The goal of in-the-field care of a seizure is to help us prevent seizures from getting into the refractory status point, to initiate therapies as soon as possible so that we can use the brain's own natural chemistry and its natural reactions to the medications that we give to help to stop the seizure and prevent it from getting to that point. So within the first 5 to 10 minutes of a seizure, we consider that to be impending status that is about to happen. Because once a seizure has reached about 7 minutes, there's about a 70% likelihood that it's going to continue for longer than that. So if a seizure has been found to be going on by about 3 to 5 minutes, which it most commonly will be when providers arrive, they should treat essentially immediately as soon as access can be established. Again, because the longer that you wait to treat that seizure, the more difficult it is to do that. Evidence shows that seizures treated within the first 10 to 15 minutes have a 96% chance of being stopped with the first dose of benzodiazepines. Once we get between the 15 to 30 minute mark, we're starting to lose options on what medications we can use to treat the patient with. And by the time we get out past 30 minutes, we have a very limited range of medications that can be used, and essentially very few of the field medications that can be used to stop the seizure at that point.
So mostly what we're using pre-hospital to treat seizures is benzodiazepines. Mostly diazepam is the prototype benzodiazepine, but a lot of agencies are going to use just a single benzodiazepine and just carrying midazolam, which is appropriate for seizures as well. The onset of action of benzodiazepine is pretty fast, either through the IV or IM route of administration. That's because they're really lipophilic drugs, so what happens is they get into the system, cross the blood-brain barrier quickly, and then are distributed into muscle and tissue. The differences between some of the common benzodiazepines like diazepam or midazolam, the onset of action of midazolam in an IV route is about 1 to 2 minutes, where diazepam can actually be anywhere up to 8 minutes. The IM administration, again with midazolam, the onset of action is going to be about 5 to 10 minutes versus diazepam, which is going to be about 15 minutes. The duration of action of midazolam is much shorter than that of diazepam, so it can be about 1 to 2 hours depending on whether it was an IV or an IM administration. IM administration is going to have a longer duration of action just because of the distribution in the tissues. For diazepam, the half-life is actually really long, about 40 hours. That's not necessarily the active half-life, but it's the terminal half-life. But either way, diazepam is a longer acting drug than midazolam. So if you do use midazolam for seizure control, you may have to repeat the doses.
Benzodiazepines are a valuable tool for stopping seizures in the pre-hospital setting. We carry midazolam. The adult dose is 2.5 milligrams. That's our max dose on pediatric population. For a child who is not breaking from a seizure, status epilepticus, we would give 0.05 megs per kg, and you can give that an IV route, IM, or IO. Hopefully I've had good success getting an IV on this kid and can go that route. That way you can hydrate them as well.
So to review, benzodiazepines work by increasing the efficiency of GABA, causing a decrease in excitability of neurons and ultimately resulting in sedation and muscle relaxation. They have a relatively quick onset of action, and their duration of action varies depending on the drug and route of administration. The commonly used benzodiazepines for seizure treatment include diazepam or Valium at a usual dose of 0.1 to 0.3 milligrams per kilogram, and midazolam or Versed at a usual dose of 0.05 to 0.1 milligrams per kilogram. As always, it is imperative that you follow your local protocols when administering medications.
In the setting of hypoglycemia and seizures, it's very important to maintain normal glycemia during seizures, both because low blood sugars can precipitate seizures, and then low blood sugars can keep seizures going once they've started. So it's important to check a blood sugar on arrival to the scene of a patient who is having seizures, and to try to correct that using D25 as soon as possible to achieve normal blood sugars. One of the most common type of seizures in the infant population are febrile seizures. They can occur anywhere between the ages of 6 months to 6 years and still be called a febrile seizure. 15 to 30% of children, depending on the population, who present with their first febrile seizure will present in status epilepticus, so seizures lasting longer than 5 minutes and not resolving on their own without medications. One of the most important aspects of treating these children is trying to bring the fever down, because the fever is actually part of the stimulus that's propagating the seizure and continuing it. And it would be recommended to ask families to either give a dose of Tylenol to bring down the fever or ibuprofen before the child is transported.
Once again, in addition to benzodiazepines, other pharmacologic treatments of seizures may include dextrose to maintain normal blood sugar, and antipyretics such as acetaminophen or ibuprofen to control fever, remembering, of course, to always follow your local protocols.
Things you can do that aren't medication related in a child to help stop a seizure is oxygen, checking a blood sugar. Try not to restrain these kids. That's the last thing you want to do, just prevent further injury prior to packaging and transporting. After the seizure has stopped, like an adult patient, a child will be postictal. They'll be confused, maybe even combative, and very scared of what's going on. They won't understand. So continue oxygen. That'll help bring them through that postictal fog a little quicker. You want to try to reassure them, have a familiar face there like a parent to help reassure that child.
Non-pharmacologic treatments of seizures should start with remembering the basics. Protect the airway, monitor respirations and support ventilations if needed, and monitor heart rate and blood pressure. Additionally, care should be taken to prevent falls and injuries without actively restraining the patient. Provide supplemental oxygen. Initiate ALS transport, including ECG monitoring, IV, and BG, and monitor closely for recurrent seizures.
So immobilizing a child's C-spine is a tricky situation, and then it can often be made worse if you have a child who's in a postictal phase. They tend to be confused, they tend to be a little combative, just like an adult would after a seizure event. So we often receive a phone call saying, do I have to immobilize this child? They had a seizure, but they fell to the ground in the setting of their seizure. And I guess my answer to that question is maybe sometimes you do and maybe sometimes you don't. Locally, I would encourage our providers to take advantage of the use of the medic phone at the University of Rochester, but again, nationwide, all EMS providers should have some physician backup available to them to ask similar questions. For most children, if they are especially very young, such as a toddler, it would be almost impossible for them to cause a significant injury to themselves by simply falling from their own height. And again, these are for children who don't have any other major medical problems. For example, it's very rare for an otherwise healthy child to really have a bleeding disorder or some type of brittle bone situation where they would be at increased risk for injury. So in general, you usually do not need to immobilize a child in the setting of just a basic seizure where they fell to the ground. Of course, should a seizure occur after a traumatic event, that would be a very different situation, and of course I would encourage you to follow your regional protocols.
Many children with known seizure disorders who are followed by a neurologist will already have a plan in place for seizure activity at home. Unfortunately, no matter how good our medicines are, many kids will still miss doses of medicines, will have illnesses, or will have other causes that will lead them to have seizures. And in some cases, we kind of know this and we kind of expect this. And so management of the seizure at home, with the help of the family and following the seizure plan that has been set up by the neurologist, can be one of the most important things for the long-term management of this child, and helping the family to acknowledge that there is to realize that there is a home seizure management plan can be a very helpful thing that EMS providers can do in the field. Many neurologists also have a hotline for their patients who have known seizure disorders or who have other known neurologic disorders to call in case of emergencies such as breakthrough seizures or status epilepticus. And calling the neurologist frequently, often at the scene can be one of those things that can be incredibly helpful for acute management of the patient at the time of the event, as well as for the continuity of care for that patient throughout their management. For patients who have frequent seizures, there are some EMS providers who actually have underlying protocols already in place for those patients should they have breakthrough seizures. And it would be important to check with the family as well as to check with the EMS providers to see if those systems and protocols are already in place for this particular patient.
For the patient who's coming in with a seizure, I think it's helpful for the parents to know that when they get to the emergency room, especially if the child is still seizing, that they may actually separate from the child for a bit so that the care providers can get the seizures stopped or under control. Being able to give a history of what happened at home will be helpful, and reassuring them that at this point when they're separated from their child doesn't know they're separated. So sometimes that'll give the parents a chance to step away and give the information if they just know they're not leaving their child awake, knowing that they're not there.
After watching this episode, participants should recognize that the goal in treating seizures is to prevent status seizures, and that the key to reaching that goal is early treatment. Participants should also recognize that pharmacologic treatment of seizures may include benzodiazepines, dextrose, and antipyretics in accordance with local protocols. Furthermore, non-pharmacologic treatment of seizures should include monitoring and supporting vital signs, preventing injuries, oxygen and ALS transport, considering spinal immobilization, reinforcing the seizure plan and neurologist notifications, and reassurance of the parents.